Good morning, everybody. I'm Dr. Cortese from Cleveland University Hospitals, and I'm very happy to present here today the preliminary results of the PICCOLETO X study, which was presented at the recent TCT as a late-breaking clinical science. So I'm very excited about this because the drug-coated balloon has been used very often, more and more, for the treatment of CTOs during coronary revascularization, but this technology still has not a very robust evidence-based medicine, and this is what we try to cover partially with this study, which aims to inform us about procedural characteristics and midterm clinical outcomes on the usage of DCB for CTO revascularization. And I'm going to start with this case that we actually performed at my institution. So this patient had a quite ambiguous cap, so we needed to use intravascular imaging to puncture the lesion. Then we prepared the lesion with a sequential ballooning. And then after lesion preparation, you address a good result. That's enough for deciding using drug-coated balloons, and this is what we did. And we took an orthogonal view showing a good result. So coming into the study, this is the largest registries on DCB with a clinical outcome. We enrolled 896 patients, all of them treated with drug-coated balloons with or without stents across the institutions that participated to the study. Enrollment was ambivalent, meaning that we collected data retrospectively and prospectively between 2013 and 2025. Primary endpoint is target lesion failure at 6 and 12 months so far for the data presented at TCT this year. And PICCOLETO X is only part of the long PICCOLETO program which dates back in 2007 with small vessel disease. And this is just one of the most recent data that we are presenting on drug-coated balloons usage for coronary artery disease patients. These are the centers and the countries that participated to PICCOLETO X. And I want to overemphasize that this is an investigator-driven trial by Fondazione RIC, which is this foundation from Milan. These are the countries participating to the study. You can see here United Kingdom, Belgium, Poland, France, Romania, Italy, Portugal, Spain, and Israel. And these are the baseline characteristics plotted by total population, solo DCB patient 458, and DCB plus drug-eluting stents 438. These characteristics quite clearly depict a common CTO patient population, nothing specifically to say about that. We included de novo CTOs and ISR CTOs. You can see here that in the hybrid or blended strategy of DCB plus DS, there were more de novo as compared to the DCB only group. And calcifications were quite frequent. In 60% of the cases, we had either moderate or severe calcifications, and the J-CTO score was 2.13 across all of the patients. Again, with the angiographic data, we have small vessel disease only in 37% of the population. So this is a step forward on the usage of drug-coated balloons also in larger vessels. So this is a quite novel indication for the usage of DCB. Double access was pursued in 84% of the cases, more in the blended therapy. We had cases with biradial, bifemoral, and radial plus femoral approach. And important, let me come back on this, diffuse disease was present in 57% of the cases. Again, overemphasizing the real-world data that we are having. In this study, we have a procedural time which was longer for the higher, for the blended therapy with DCB plus drug-eluting stent, probably reflecting the fact that here the population had more complex coronary artery disease. Same for contrast volume usage, which was higher there, and the fluoroscopic time. but the percent of success was quite similar with 2.97 across all of the groups. We had a one-to-one lesion predilatation according to the ARC DCB guidelines in 80% of the cases, which is pretty good. For the crossing strategy, not surprisingly, the majority of the patients underwent antegrade wire escalation, 80% of the cases more in the DCB only. And this is not surprising because if we go for a ADR approach, you would prefer to put a stent instead of delivering the drug outside of the lumen. And this is one of the reasons why more patients there were treated with a blended therapy. In terms of DCB length, we have an overall 46 millimeters of length, a little bit higher in the DCB only group. And as per diameter, we have a 2.69 millimeters on average. In-hospital outcome is quite similar to other registries on CTOs. We have AKI occurring in 3.4% of the cases, perforations in 5% of the cases, but only a minority of them did need pericardiocentesis. Periprocedural MI occurring 1.7%, a little bit higher in the DCB only group, but all-cause death was not different. There were more retrial lesions in the DCB plus DS group, but these were elective retrial lesions within the same hospitalization. And this is the primary outcome at 6 and 12 months, showing a 15% and 18% occurrence of TLF in both groups. So no differences between DCB only and blended therapy DCB plus drug-eluting stents. And again, here we have no differences between the two groups as pertains all of the other elements of the primary endpoint: cardiac death, non-fatal MI, target vessel MI, TVR, and TLR, showing the safety of using a DCB approach for CTO without any single case of thrombotic occlusion during the follow-up. This data well aligned with the ER-CTO registry, which has been recently published, but which only reports on in-hospital outcome with DCB for CTO. So we well align on that, showing that in the solo DCB arm, we have a good safety performance without, and also with a lower usage for a contrast dye and a lower fluoroscopy time. And for the first time, we report here, according to the literature data, a midterm outcome at 6 and 12 months on a usage of DCB, which, as I said, is safe in this category of patients and can be used also in a blended fashion without increasing the risk of periprocedural MI, but allowing a shorter and a reduced total stent length in the very complex cases. We have several limitations that we have to acknowledge about this study. First of all, we were more prone to use DCB versus the in-lumen AWA approach for CTOs. This is the first thing that we need to know. And this is not a purely prospective registry, and this is not a randomized trial. And there is also a bias towards the allocation versus between DCB and DCB plus drug-eluting stents according to the preferences of the operator. We don't have also a complete information about the procedural techniques and the reasons why these techniques have been applied here. And so far, we don't have information of comparison between the performance of paclitaxel and sirolimus-coated balloon, but these will be disclosed soon in the next meeting. So in conclusion, in this large real-world registry, drug-coated balloon-based treatment of CTOs, either alone or with drug-eluting stent, were associated with favorable midterm outcome. So these findings support feasibility of DCB application during CTO intervention and underscore the need for further prospective trials, possibly randomized trials, especially in the setting of long lesions, as compared to full drug-eluting stent approach.